Well, good morning. It's my pleasure to kick off this session on emerging trends and therapies you need to know about as part of our heart failure in primary care session today. Here are my disclosures. So as I planned this presentation, I thought I would leave you with three learning objectives. The first are to review data that I think most of you are quite familiar with, which is the interrelationship between type 2 diabetes, obesity, cardiovascular disease, and specifically heart failure, which is the focus of our symposium. Secondly, I'd like to review how the cardiovascular outcome trials of the two new therapies for diabetes that we've become available to us in the last 5 to 10 years, namely GLP-1 receptor agonists and SGLT2 inhibitors, how their use in patients with type 2 diabetes, which are at high risk of cardiovascular disease, inform the management of heart failure. And thirdly, I'll shift to where looking at SGLT2 inhibitor use in patients with heart failure specifically, independent of type 2 diabetes. And in fact, very recent data, independent of whether they are low ejection fraction or normal ejection fraction heart failure. So let's begin. These are data from the Swedish National Diabetes Register. And as you'll appreciate, they span a number of years, almost 2.5 decades, and it's about 500,000 patients in this registry. And the red line shows the mortality from cardiovascular disease in patients with diabetes, which, although declining, is still about 1.5 to 2 times higher than a similar mortality of patients without type 2 diabetes, shown in the yellow line. Our own data from the Public Health Agency of Canada are summarized here. We've known for many years that the risk of developing cardiovascular events such as stroke, MI, and ischemic heart disease is about 2 to 3 times higher in individuals with diabetes compared to those without diabetes. And I think most of the audience is also aware that with regards to end-stage renal disease, diabetes imposes the single greatest risk in society for the cause of end-stage renal disease needing dialysis or renal transplant. And what's often less appreciated is the risk of heart failure, which is about 4 times higher in individuals with diabetes than in individuals without diabetes. And I'm going to focus a lot of my comments on heart failure. Broadly speaking, though, while we understand this risk and association between diabetes and cardiovascular disease, what's been challenging until recently has been efforts to reduce that risk. So this is analysis by Cossack Ray in the United Kingdom, published about a decade ago. It appeared in the Lancet in 2009 and was his attempt at quantifying where the greatest benefit lies. And what the blue bar will show you is that by reducing systolic blood pressure in patients with diabetics for 5 years, you get a very significant reduction in cardiovascular events. The red bar shows reductions in LDL, also translating into very significant reductions in cardiovascular events. And what was disappointing a decade ago is that reductions in A1C led to the least benefit of all of these risk factors. Why is that? Well, as highlighted in the red, it's because these data are based on the use of traditional glucose-lowering treatments. And as this complicated slide lays out temporally, we started by having insulin, sulfonylureas, and metformins for decades. And really only until the late 90s, we began to use TZDs or PPAR gamma agonists. And then in the mid 2000s became available GLP-1s and DPP-4 inhibitors. And really only in the last 7 or 8 years have we had open access to the SGLT2 inhibitors. And that's when a lot of the data demonstrating finally reductions in cardiovascular outcomes emerged. This, of course, was mandated by the FDA because of the less than beneficial effects of TZDs, which actually caused an increase in risk of myocardial infarction and heart failure. Now let's look at the first of these cardiovascular outcome trials, the DPP-4 inhibitors. As these data will show you, they increase the risk of hospitalization for heart failure. This was seen with saxagliptin in SAVOR-TIMI 53, in SAVOR-TIMI study, and in the EXAMINE study with alogliptin. While these results were somewhat surprising and not consistent, in other words, they didn't hold true with sitagliptin or linagliptin, they did cause some pause and concern for the use of incretin-like therapies in diabetes. I'll remind everyone, though, that the overall results of these studies were neutral. No harm, no benefit. At this same time, my colleagues Jay Udell and others here in Toronto published this meta-analysis looking at 95,000 patients in 14 different trials, followed for about 4.5 years, and there were about 4,000 heart failure cases. And what Dr. Udell and colleagues showed is that while intensive glucose lowering could reduce MACE, the effects were modest, and the effects on MI were also modest. But the cost of this benefit actually was a 14% increase in the risk of heart failure. And this was a very important observation. And in the conclusion of their study, they suggested that it was due to some drugs more than others. And they also identified that it might be related to the effect of these medications on weight gain. For example, with insulin and TZDs, less so with DPP-4 inhibitors, there might be weight gain. They quantified this as a 7% increased risk of heart failure for every kilogram of gain in weight. Well, what do we know about body weight and diabetes? On the x-axis here, you'll see different BMIs. And to the extreme right, BMI over 30, you'll appreciate that in the pink bar, over 50% of patients with BMI over 30 have hypertension. About a third have dyslipidemia, and only 20% have diabetes. These are data from China, but they're identical data available from almost any geographic distribution across the world. So what this data tell us is that these comorbidities flock together. Diabetes, obesity, and hypertension move together. And if we're to treat one, we have to be sure that we're treating all of them. And why do I stress this point about diabetes and obesity? Well, in the Look Ahead study, which is a study that randomized people to intensive lifestyle intervention or regular diabetes support and education, the overall results were neutral. But if you look at the people who were responders, and those are people who did lose 10% body weight, you'll appreciate they had a 20% reduction in the primary outcome of death, MI, stroke, or admission to hospital for angina, and a 24% reduction if you added revascularization and heart failure to that primary outcome. In other words, people who successfully lost weight, who were diabetic, had better outcomes. And this is kind of implicit to our understanding of the pathophysiology of heart failure. I've shown you obesity relates to diabetes, dyslipidemia, and hypertension. These are the three cardinal risk factors of developing atherosclerosis. And diabetes and hypertension together are the leading causes of nephropathy. And once nephropathy progresses and becomes significant, you accelerate atherosclerosis even further to develop the highest incidence of coronary disease in that population. And then if you have ischemic heart disease, renal disease, hypertension, you're bound to develop heart failure. And in fact, there's a direct relationship between diabetes and heart failure that's independent of these conditions, which I don't have time to delve into. Now, it's just not about having heart failure as a consequence of diabetes, it's the mortal impact of that. In this long-term follow-up of diabetic patients over the age of 65 in a Medicare claims database, you'll appreciate the red line shows you how serious having diabetes with an episode of heart failure is. There's an 80% mortality at 5 years. You might say, well, these are old data. But now, today, in 2020, in this analysis of administrative databases from 5 European countries plus Japan, you'll appreciate the blue line shows that the most common first event in patients with type 2 diabetes who have no pre-existing cardiovascular disease the most common thing they'll develop is either heart failure or chronic kidney disease. And this has significant mortal impact. You'll notice how much more frequent kidney disease and heart failure is than stroke, MI, or peripheral artery disease, which are the other three lines on these graphs. What's the mortal impact? In this same study published earlier this year, they looked to find what were the causes, what were the diseases that were most associated with all-cause death. And the greatest single one was heart failure. Second was chronic kidney disease, but if you had both of them, your risk was highest. And this held true as well for cardiovascular death. In other words, having a background history of MI or stroke or even peripheral artery disease was not as dangerous as developing heart failure or chronic kidney disease. Of course, everything changed when these studies were published. Within 6 to 9 months of each other, EMPA-REG Outcome and LEADER, one, the first cardiovascular outcome trial with an SGLT2 inhibitor, the other, the first cardiovascular outcome trial with a GLP-1 receptor agonist, for the first time showed that these agents reduce the risk of CV death, MI, and stroke, with the curves diverging very quickly with SGLT2 inhibitors, less quickly for GLP-1 receptor agonists. Why do these drugs, unlike other drugs, have this benefit? Well, in this plot of the various metabolic effects, which I've summarized here, there is a reduction in A1C, but also reduction in weight, systolic blood pressure, and improved lipids with GLP-1 receptor agonists. With SGLT2 inhibitors, all of those things hold true except for the changes in lipids, but the magnitude of the benefit is less significant than that with GLP-1 receptor agonists. Does this hold true in the outcome trials overall? Let's have a look. If I look at this analysis of all 7 GLP-1 receptor agonists cardiovascular outcome trials, there are 56,000 patients, and the overall reduction in 3-point MACE is 13%. In cardiovascular death, it's 12%. And here, importantly, in hospitalization for heart failure, it's 9% overall. So these agents, GLP-1 receptor agonists, do not worsen heart failure. They are, in fact, beneficial for heart failure, but that's not where their big impact lies. Let's compare this to the SGLT2 inhibitors. Here we see that the MACE reduction is modest. It's only 10%. But if we move now to look at CV death, it's 15%. And the most important impact is hospitalization for heart failure, where there's a consistent benefit no matter what agent is tested. It's around 30% reduction in hospitalization for heart failure. So this is a very important drug in heart failure. And in these trials, we know that some of the patients had pre-existing heart failure. So this is an analysis looking at CV death and hospitalization for heart failure, whether or not you had heart failure in these diabetic individuals. And a history of heart failure, the hazard ratio still shows a 30% reduction, and with no history of heart failure, a 21% reduction, suggesting that perhaps this drug would be a heart failure drug, even if you didn't have diabetes. And let's look at those data now. DAPA-HF was the first study, about 4,500 patients. You needed to have NYHA class 2 heart failure, you needed an EF of less than or equal to 40%, and you needed an elevated N-terminal proBNP. The similar study, Emperor Reduced, had similar inclusion criteria, but was a smaller study, about 3,500 patients. Let's now look at the baseline characteristics. These show that the LVEF in patients in the Emperor Reduced study was somewhat lower than those in DAPA-HF, 27% versus 31%. The eGFR was somewhat lower in Emperor Reduced than in DAPA-HF, 62% versus 66%. And the use of sacubitril valsartan, combination RAS inhibitor with neprilysin inhibitor, was more frequent in Emperor Reduced, about 20% versus 10%. Now let's look at the primary outcomes. In DAPA-HF, there's a 26% reduction in its primary outcome, which included urgent hospitalization for heart failure. If I take that out, it's a 25% reduction, CV death or hospitalization for heart failure. If I just focus on death, it's a very remarkable 17% reduction in patients treated with dapagliflozin. Emperor reduced the identical 25% reduction in the primary outcome of death and hospitalization for heart failure. In Emperor reduced, however, there was no reduction in cardiovascular death. However, in the CVOT for type 2 diabetes, which would declare an EMPA-REG outcome, the inverse was seen, was that CV death was reduced in EMPA-REG outcome, but not in declared. I believe this is chance. What are we left with? These are the summary of DAPA-HF and Emperor reduced. We see between 25 and 30% reductions whether or not patients have diabetes. And really importantly, just last week, the Soloist study was published. Here, a smaller study, but now we have data in both the dark blue, which is people with reduced ejection fraction heart failure, and in the light turquoise color of people with preserved ejection fraction heart failure. And you'll appreciate the relative risk reduction was greatest there, although the numbers are small. So to end, the SGLT2 inhibitors have become central to the management of heart failure, both in their prevention, as shown on the left-hand side with all the pink bars, and on the right-hand side with all the orange bars. We've yet to hear from DELIVER, which will be DAPA in preserved ejection fraction, or Emperor preserved, which will be empagliflozin in preserved ejection fraction. But Soloist tells us that there may be benefit even in preserved ejection fraction. And Soloist was also different in that it was an acute heart failure study. So I've not gone into mechanisms. My colleagues who will follow will talk about kidney disease, but suffice it to say that these medications work by reducing preload, afterload, wall stress, edema, and myocardial oxygen demand, and have significant benefits. To summarize, I started with 3 objectives, and I'm ending with those same 3. Diabetes, obesity, heart failure, and CKD are intimately related, and we should coordinate their management. Cardiovascular outcome trials of these 2 new classes, the GLP-1s and the SGLT2s, guide us to recommend SGLT2s in patients with heart failure. And finally, data supporting SGLT2s in patients with HFrEF are strong and independent of underlying type 2 diabetes. In fact, they appear to be encouraging in acute heart failure with diabetes, including those with heart failure with preserved ejection fraction. Thank you very much.